Ciao mondo, hello world, hola mundo, hello monde, konnichiwa, ni hao, namaste. We're here today taking a cappuccino with Dr. Francesca Francescacchi from the Department of Critical Care, Atticon University Hospital, National and Kapodistrian University of Athens Medical School in Athens, Greece. So, Kalimera, Yasu Kosmote, as they say in Greek. Thank you for joining us today. And the topic of this cappuccino is the use of HA380 JAFRON cartridge in patients with septic shock. The question is, do you think is the mortality the right endpoint for studies, or do you think we can have other surrogate markers for understanding better this treatment?
Kalimera, good morning, Professor. Thank you for the kind invitation. I don't think that the mortality could be an endpoint for septic shock patients. It's very difficult to study the mortality in those patients and to perform randomized control studies. On the contrary, we can use surrogate markers as the cytokine levels. Actually, we use the level of interleukin-6, which we can easily measure in our hospital, and also the ferritin levels. Another surrogate marker could be, but this is for investigational reasons more, and I don't know how we can use that in clinical practice, the HLA-DR levels.
We did that also, and we found very interesting results with improvement of presentation of the antigen. But one question is, therefore, I think also that hemodynamic parameters can be important, no?
Yes, it's very important too. This is the other parameter that we have studied with hemoabsorption. And actually the noradrenaline dosage, we have observed that after the sessions of hemoabsorption, the 3 days, we observed lower levels of noradrenaline. The patient needed lower levels of noradrenaline.
So you used this for 3 days, and how long was each session?
6 hours each day, 3 levels for 6 hours. And we measured the interleukin levels before and after, and also the clinical parameters.
What kind of anticoagulation did you use?
We use heparin, unfractioned heparin, targeting to an APTT of 50 or 60 or something like that. We try to do that regulation, and the filter functioned perfectly. The function was perfect. Okay, so
can you repeat the dose you used?
We used unfractioned heparin, about 300 or 500 units per hour.
Per hour.
Yes, targeting to an APTT level or 50 or 60 or something like that. It depends on the patient.
Okay, excellent. Now, do you have a criterion to stop the treatment?
Actually, we stopped the treatment earlier if the patient was very hemodynamically unstable, so we couldn't go on with the flow. But we didn't. But this happened rarely, very rarely.
So, how many patients have you treated so far?
We had about 10 patients. We have already treated 10 patients, septic patients, and 5 with COVID-19.
Ah, okay. So you also used in COVID-19. We also did that, and especially when there is a possibility of development of cytokine release syndrome. Now, this is a question that I have also made to other people. we prefer to start quite early in the treatment to prevent organ damage. What is your criteria to starting?
If the patient seems to be very septic, and we also use ferritin levels, and also the noradrenaline, the dosage of noradrenaline. For example, we had a patient with acute pancreatitis, and the level of noradrenaline was quite high, and the CRP was also high. So we started earlier. And the patient did very well. Actually, we saw that the levels of CRP and interleukin 6 were lower, and also the patient was better. And actually, he didn't need any more noradrenaline after the last session of treatment.
This is also our experience. So I think this is a very important new tool in the hands of intensive care physicians for treating septic patients. We have listened yesterday to different absorption therapies, and it seems that this is one of the promising approach for patients who have cytokine release syndrome and pro-inflammatory mediators at very high level. And in a very short period of time, we see a decrease in requirement of noradrenaline and also improvement in hemodynamics. Together with that, we also have seen improvement in HLA-DR expression. So a kind of immunohomeostasis that is reconstituted. Well, with this, we thank you very much. We thank your Athens Medical School. It is a pleasure to have Greece among the audience and the faculty of the Vicenza course, and we're going to continue with the scientific program. With this, I drink my cappuccino, and I invite you next year to join us in person in Vicenza, Italy. Excellent.
Thank you very much, Professor. We will come with pleasure. Excellent.